Hello students, I am Dr. K. Saravanan, Associate Professor, Department of Oral and Maxillofacial Surgery, Vinayaga Mission Sankaracharya Dental College, Salem. Today I am going to talk about correction of dentofacial deformities. Have you noted the discrepancies of jaws, maxilla, upper jaw and lower jaw? In this, I am going to talk about these objectives, that is understanding the indications for surgical correction of dentofacial deformities, to know how to diagnose skeletal problems, to understand various maxillary osteotomy procedures, to understand various mandibular osteotomy procedures, to know the step-by-step preparation for surgery, and finally to know and manage the complications. The deformities of the jaws can be maxilla and mandible. Maxilla can be excess maxillary deficiency or hypoplasia in terms of transverse, vertical or three-dimensionally. Coming to the mandible, mandible can be excess, that is prognathism, or mandibular retrognathism, a small jaw, or can be a true maxillary or mandibular excess or defect, can be relative defect or the combination of both. We call it as facial asymmetry. Coming to the incidence, 20% of the population will have such deformities of jaws. So what do you think is the need for correction? We have to give a better aesthetics, we have to give a good function. So these are the basic objectives and need for jaw corrections. So orthognathic surgery, ortho means straightening of jaw, gnathic means jaw, as you all know. So it is the art and science of diagnosis, treatment planning and execution of the treatment by combining orthodontic and oral and maxillofacial surgery, that is our department, to correct the musculoskeletal, dento-osseous and soft tissue deformities of the jaws and the associated structures. The goals we going to attain are function, aesthetics, and thereby giving a better stability to the jaws and the musculature, thereby minimizing the treatment time. When you go back to the history, in 1859, Orn Lagenbach did the anterior maxillary osteotomy for removal of pathologies like polyps. In 1867, Chiver did the treatment for complete nasal obstruction, that is maxillary down fracture. In 1927, Wasmund did anterior maxillary osteotomy for correction of midfacial deformities by using orthopedic force. In 1942, Schudert advocated pterygomaxillary disjunction for total maxillary deformities. In 1965, Aubigazar did a complete mobilization of the maxilla so that a repositioning can be accomplished without tension in all three dimensions. Bone grafting to enhance the stabilization for Leaford and anterior maxillary osteotomies are advocated by Cooper, Gillies and Rowe and Aubigazar. Aubigazar is now, we call it as father of modern orthognathic surgery. Types can be of maxillary osteotomy procedures, mandibular osteotomy procedures. Maxillary osteotomy procedures can be segmental osteotomy procedures like single tooth osteotomies, corticotomy, anterior segmental maxillary osteotomy, posterior segmental maxillary osteotomy and total maxillary osteotomies such as Leaford 1, 2 and 3. Other procedures are surgically assisted maxillary expansion, quadrangular Leaford 1, Leaford 2 osteotomy, high level midforce osteotomy. The sequence of planning can be conventional approach, surgery first approach. What is conventional approach? A conventional approach is first start with the pre-surgical orthodontics for correction of spaces, derotation, eliminate the dental interferences, that is teeth interferences, followed by surgery, and then post surgical orthodontics, that is for settling of occlusion, a finer teeth alignment. SFO, surgery first approach, that is first we do the surgery followed by post op orthodontics. Indications can be of skeletal cases such as class 2, that is severe maxillary excess, class 3 severe mandibular excess, facial asymmetry cases, or ankylosis cases. Advantages for surgery first approaches are decreased treatment time, better patient satisfaction. Start with examination. First is a clinical complaint. What is the chief clinical complaint from the patient? We have to document it, and followed by clinical evaluation, vertical as well as horizontally. We have to evaluate which third of the face is excess. Then occlusal relationship, midline discrepancy right from the soft tissues and the hard tissues, overjet, overbite, crossbite, occlusal cant, incisor inclination, crowding and spacing, tongue size, mobility, speech pattern, followed by radiological examination. Have to get a OPG orthopentamogram, lateral ceph, and if possible CT. In the lateral ceph, we have got a specific landmarks, soft tissue landmarks and hard tissue landmarks. Accordingly, we do the tracing and find out what exactly the problem is. Then the models, the upper and the lower impressions of cast of the maxillary teeth and the mandibular teeth are poured, and we get the study models, and we articulate it in a 3-point articulator to simulate a patient maxillary and mandibular jaw, and then we do a mock surgery first on the model, and then we decide whether the treatment plan is right or not, and then we go for patient treatment. Images, we have to document a frontal, lateral and a semi-lateral images of the patient. For surgery, we have to do a workup, getting the lab investigations, informed consent from the patient, from the patient's parents, and we need a psychological counseling prior to the surgery. Coming to the segmental osteotomies, can be single tooth osteotomies. Single tooth osteotomies are indicated in case of a trauma. Mostly there will be intrusion of either of the anteriors and thereby landing in dental ankylosis. Sometimes there will be diastema. So closure of diastema, we need single tooth osteotomy. The vertical cuts are placed 1 to 2 millimeter on either side of the proposed bony region, labially as well as palatally, up to the depth of the cortex, and then horizontal cut is placed 5 to 6 mm above the apex. Then the cuts should be placed only to the cortex. The advantages are reduction in the treatment time, lower incidence of relapse. The disadvantages could be injury to the tooth, periodontal compromise. If you are not making the cut precisely 5 millimeter above the apex, then we will end up in devitalization of the teeth. All these are followed by orthodontic treatment. Corticotomy. Corticotomy is like a single tooth osteotomy, that is for anteriors. The depth of the cortical bone should be 1 to 2 millimeter depth till the cortex on both labial, palatal side. Horizontally 5 millimeter above the apex. So the bones are removed in a radical fashion. Okay. Repositioning of the teeth with the ortho treatment between 6 to 12 weeks. This is how we do it. Here vertical cuts 5 millimeter above, horizontal cuts are placed, and the cuts should pertain only to the cortex. okay, on labial as well as palate. So, the horizontal cut on the labial side and on the palatal side. So, this facilitate fastened movement of the dentoalveolar component, so that the treatment time is reduced. Anterior maxillary osteotomy, it was first given by Cornstalk in 1921. Indications: bimaxillary protrusion cases, severely protruded maxillary teeth with normal inclination to the alveolar bone, that is dento-alveolar protrusion. Anterior open bite, when orthodontic treatment are not possible for reasons of periodontal compromise, to reduce the prominence of upper lip. This is one such case. 3 techniques are there. Wasmund technique in 1935 advocated a buccal as well as a anterior vertical incisions, and then place the cut, osteotomic cut. Tunneling can be done on with this incisions. Transpalatal osteotomy cut should be done with the buccal cut. Occasionally mid-palatal sagittal incision can be given. Then Wunderer in the year 1963 modified it. Instead of giving a buccal, he advocated for palatal cuts, transpalatal incision combined with a vertical buccal incisions. So, this is how the palatal mucosa is reflected and transpalatal osteotomy is done. Cooper, he advocated for a buccal vestibular incision and then a horizontal cut done along the piriform margin, vertical cut done along the long axis of the premolar on both sides, and then transpalatal osteotomy was done under direct vision. So, we mostly do anterior maxillary osteotomy by this method, Cooper method, that is 4 extraction, then a vertical osteotomy cut and then horizontal osteotomy cut, and then nasal septum, nasal clearance soft tissues are cleared and then down fractured, set it in a desired position and then fix it with plates and screws. So, this is a pre-op picture and this is a post-op picture. This is a semi-profile and this is a profile picture of the patient post-operatively. This is yet another case where AMO is done, post-operative picture. This is a pre-operative and this is a post-operative picture. Posterior maxillary osteotomy. Schudert in the year 1959 first reported this. The indications for posterior maxillary osteotomy are maxillary hypoplasia, a repositioning of the posterior segment, posterior open bite, a transverse excess or deficiency, cross bite cases, and spacing. So, the technique would be a vestibular incision below the buttress and expose the bone, maxillary buttress, maxilla and posteriorly, and then osteotomy was done buccally and very rarely palatal incision was done, and then pterygomaxillary disjunction. This is a cut. This is how the pterygomaxillary disjunction is done with the help of a osteotome and then reposition. Total maxillary osteotomies, Leaford osteotomy. Leaford 1 osteotomy, cases of maxillary hyperplasia or hypoplasia or cant, we can do Leaford 1 osteotomy, we can treat it with the help of this procedure to correct the occlusal plane. So, vertical maxillary excess, a horizontal maxillary excess, the long narrow face can be corrected using such osteotomy procedure. First, we do a vestibular incision, expose the piriform margin till 6 to 6 and then do the osteotomic cuts buccally, start from the piriform aperture, go laterally, join with the zygomatic buttress and then posteriorly pterygoid disjunction. When there is excess bone, can be removed. This is a 3-dimensional view. This is a lateral cut, lateral wall of nose cut, osteotomy, and this is a nasal septal cut, osteotomy cut. This is how the excess bone is removed, and this is how the soft tissue clearance is done with the help of a septal chisel, alar nasal chisel or guarded nasal chisel. So, we have to relocate or detach the nasal floor with the help of the guarded nasal and septal chisel, so that the bony fragment alone is down fractured. Finally, pterygoid disjunction is done. There are 2 modifications. Directly you can do a pterygoid disjunction, or else you can go with the third molar socket procedure, that is Thimble's modifications. While doing the medial wall cut, we should be careful doing a descending palatine, because descending palatine artery will come there. So, we have to cauterize it after down fracturing it without traumatizing it. This is after plates and screws repositioning. So, placing the incision, markings, exposing the bone, removing the excess, pterygoid disjunction. This is down fractured and descending palatine is cauterized. This is fixation with plates and screws. Maxilla, down fractured maxilla is stabilized. So, this is a pre-op picture, this is a post-op picture. This is a pre-op picture and post-op picture profile view. This is one more case, vertical maxillary excess. Leafort 1 osteotomy was done, down fractured and intruded 6 mm up and stabilized with plates and screws. This is a post-op picture of the patient. Leafort 2, this is just higher level, that is nasomaxillary hyperplasia such as Bind syndrome, reduced or retruded nasomaxillary complex resulting from mal or non-treated Leafort 2 fracture, cleft lip palate or nasal midface hypoplasia. Incision for this osteotomy would be a coronal incision, a median brow incision, a paranasal incision. So, the osteotomies are done along this fashion, Leafort 2 subzygomatic, and then we have to connect it with a Leafort 1 osteotomy. Repositioning is done by plates and screws. Modified Leafort 2, in that only nasal component alone is repositioned. Leafort 3 osteotomy, the indications would be nasomaxillary hypoplasia along with the underdeveloped malar bone, a retruded midface due to trauma in case of any syndromes, pseudoexophthalmos, shallow orbit or hypertelorism, traumatic or a telecanthus. So, this is again with the coronal incision. This is a higher level. This involves zygomatic bone along with a Leafort 1 osteotomy. So, frontally repositioned and stabilized with the plates and screws. Okay. So, till now we have discussed about a single tooth osteotomies, anterior maxillary osteotomies and segmental followed by total maxillary osteotomies. How such osteotomy is done and repositioned? What will happen to the repositioned jaw and to the teeth? So, there is a biological basis behind this. Bell and et al. In 1965, he did many studies in animal models and they concluded that revascularization happens in 5 to 6 millimeter if we place the osteotomy cut 5 to 6 millimeter above the apicus. Pulpal revascularization and even sinus revascularization happens. So, no necrosis will occur because palatal pedicle is intact. The palatal pedicle is supplied by the ascending palatine branch and from pharyngeal artery branches. So, the sinus will be we will get a good lining on the sinus 6 months post-operatively. So, this forms the biological basis for proceeding or for doing such osteotomies. Complications: inadequate orthodontic preparations or lack of communication between orthodontist and us, inability to achieve a pre-operative goals, a lack of marking maxillary and chin midlines, absence of surgical splint in case of surgeries, TMJ abnormalities. Any pre-existing TMJ abnormalities will land up in problems, post-op complications, and of course over expectations of the patient. We have to inform the patient that we are repositioning the jaw or the particular maxilla, upper jaw or lower jaw for 3 to 4 millimeter. We have to instruct them clearly, like you will get a better face. So, the complications of maxillary osteotomies, airway. So, while doing nasal osteotomy cut, we have to be careful. We should not go aggressively because intubation will be there and bleeding. So, we have to cauterize the descending palatine artery, identify it before itself, and malpositioning. For that we need a splint to prevent malpositioning. Perfusion deficiency, periodontal defects. If we place the cut exactly 5 millimeter above the apex, these complications will not happen. Infraorbital nerve will be there and we have to go below the infraorbital nerve. Palatal cut usually done indirect way, that is by tunneling. We should not tear it. This will prevent the oronasal or oroantral fistula. So, if we impact 5 millimeter above, then we have to do a septoplasty to prevent nasal deviation, to prevent we have to do alar cinching also to prevent a broadening of nose. Maxillary sinusitis will be there and can be managed with antibiotics. Mandibular procedures. Mandibular procedures can be mandibular body osteotomies, anterior body, posterior body osteotomies, segmental subapical osteotomies, anterior subapical osteotomies, posterior subapical, total subapical osteotomies, genioplasties, augmentation and reduction. Body osteotomies are not usually done nowadays. Body osteotomy described by Blair in 1907, it is usually done for mandibular setback, advancement, anterior open bite, closure. This is how the body osteotomy is done. Anterior osteotomy, as I mentioned in maxilla, anterior maxillary osteotomy, this is anterior subapical, that is lower subapical osteotomy, we call it in these words, that is extraction of 4-4 and followed by a vertical osteotomy cut and a horizontal osteotomy cut 5 mm above the apices. So, this is total mandibular osteotomy described by Halligan in the year 1849 and modified by Hofer. Ramus osteotomies. These are the popular osteotomies that are being done now. Inverted L osteotomy, vertical subsigmoid osteotomy, bilateral sagittal split osteotomy. Inverted L osteotomy. As the name suggests, inverted L, the cut placed from the anterior border of ramus till posterior to the lingula and then a vertical cut is done. This is mostly done intraorally. So, for advancement you can do inverted L osteotomy. Vertical subsigmoid osteotomy. A vertical cut instead of a L shaped cut, in this we can place a vertical cut from the sigmoid notch posterior to the lingula till the lower border. It can be of intraoral or extraoral procedure, mostly done in intraorally. For a setback less than 8 millimeter, we can do a vertical subsigmoid osteotomy. Sagittal osteotomy, BSSO, bilateral sagittal split osteotomy. This is a popular technique that is being done for minor corrections, lower jaw corrections. Abwegeser and Trana, he was the one who first identified and advocated this technique. He placed a buccal incision lower and then medial incision like this, and he made a cut horizontally. Later Dupont he modified it. He brought the anterior cut buccally and then lower. Hansak, he limited the posterior cut going till the posterior border to the just above the lingula. And finally, Bell and Epker in the year 1977, he advocated for a bicortical cut at the lower border and minimal stripping of masseter muscle. This is how the incision is carried out. So, exposure of a bone, full thickness mucoperiosteal flap is reflected. This is the vertical cut, this is the medial cut. This cut should pertain only to the cortex, and then we have to connect it. This is postage stamp technique. So, this is connected, this is a connecting cut, and then this is pried using the osteotome. So, split is done sagittally into two. This is to show how the cut would go. So, above the lingula, 5 millimeter above the lingula. Here before the second molar and the first molar, or sometimes we can go between the second molar and third molar also. So, we can advance this or we can set it back. Mostly the nerve should be on the distal aspect. This is the proximal segment. The condyle bearing segment is the proximal segment, tooth bearing segment is the distal segment. Then we have to fix it with the plates and screws. IMF needed, we can do it. This is how the cuts are placed post-op. This is a case of severe mandibular retrognathism, osteotomy cuts placed, reposition, and this is a post-op picture. Coming to the genioplasty. Genioplasty is a procedure done for advancement, reduction or sliding or differential positioning of the chin. This is usually done between the two mental foramens. So, vestibular incision is placed and a full thickness mucoperiosteal flap is raised, and then a horizontal osteotomy cut is done from below the two mental foramens. The nerves are preserved, and then below the two mental nerves the osteotomy cut, oblique osteotomy cut are done, and then it is completed fully and it can be repositioned, either advanced or set it back, or excess can be removed. Two cuts, in case of a severe excess and asymmetry is seen, we can reposition the middle fragment. So, the lesser fragment comes to the one side and the larger fragment goes to the other side. This is propeller genioplasty. So, this is advancement, reduction, genioplasty. So, this is a case of advancement genioplasty along with lower subapical osteotomy. So, the middle bone is left behind to have a contact and stability for plating. So, this was a pre-op picture of the patient. This is a post-op picture of the patient. In this patient, Leafort-1 osteotomy was done along with lower subapical and advancement genioplasty. Complications: malocclusion, open bite, lateral shift or unfavorable shift, a fracture in case of prying the mandible with the help of osteotome. If we give excess force, and thereby what will happen, these fractures will happen either to the proximal fragment or to the distal fragment. So, what we have to do is minor fractures. So, we have to orient these fractures with the small plates, mini plates to the bring it to the proximal fragment. We have to have only two fragments, proximal or distal. So, small fractures can be brought it down if possible and orient it with the help of a proximal segment and then distal segment. Hemorrhage can be controlled. Nerve injuries, we have to be careful enough, and even after surgery 4 to 6 weeks there will be paresthesia. So, condylar positioning, so we should have a surgical splint. Nowadays STF models are there, 3D and the splints can be fabricated. With that we can prevent the condylus sac, thereby we can prevent relapse. Okay. So, orthognathic surgery means the correction of dentofacial deformities such as upper jaw deformities, lower jaw deformities with respect to 6 to 8 millimeter, maximum 6 to 8 millimeters we can do. What will happen, or what has to be done if the discrepancy is more than 1 centimeter or like that? For that we have to do distraction osteogenesis. So, distraction osteogenesis is the answer for a severe skeletal discrepancies. So, it is otherwise called as callostasis, callus distraction, osteodistraction. This is nothing but you break the bone into two and then you fix a device called a distractor device, and with that slowly you distract it 1 millimeter 1 millimeter. So, the regeneration of bone between the two fractured or osteotomized cut surfaces that are being separated. The concept was given by Alexander Codeville in the year 1905. Later Elizaro modified it. So, it was used for lengthening of lower limbs in World War II days. Three vectors are possible: a vertical, a horizontal and a oblique. The distractors can be of intraoral, extraoral, uniplanar, multiplanar. 4 phases of distraction are there. The first one would be the osteotomy phase, that is placement of the osteotomy cut, and then you have to fix the device and then leave it for 3 to 5 days. That is the latency phase, and then after 5 days you start activating it 1 millimeter per day. This 1 millimeter can be split up as morning 0.5 and evening 0.5 mm. Okay, and we have to mark it out and we have to activate it till we achieve the desired position. Okay, and then starts the consolidation phase. Consolidation phase is 3 times that of activation phase. If suppose the activation phase is 30 days, then the consolidation phase would be 90 days. So, consolidation phase is making the soft tissue callus or a waiting period for a soft tissue callus to become a hard tissue callus. So, this is a extraoral distractor device. This is after distraction. See the changes, notable advancement. So, this is after distraction and the removal of a distraction, chin advancement and AMO is done. This is repositioning, this is a post-op picture, this is after review. So, correction of jaw deformities will automatically or will in turn correct the obstructive sleep apnea. So, obstructive sleep apneas could be because of a smaller jaw, small jaws. Okay. So, maxillomandibular advancement could be the procedure or treatment for correction of obstructive sleep apneas. So, these are the case series: true vertical maxillary excess and shortening of chin. So, Leafort 1 osteotomy and then advancement genioplasty was done. So, this is a pre-op and this is a post-op picture, and this is also a vertical maxillary excess and deficient chin. So, Leafort 1 osteotomy and chin advancement. Then this is a post-op picture. This is pre-op, this is post-op, and this is a forwarded placed and the patient is not happy, and the patient gives a clear history of his forwardly placed lower jaw alone. So, this is a lateral shift, this is a treatment plan. What I planned is BSSO setback, BSSO setback. This is a post-op picture of the patient, and this is the pre-op and post-op picture. So, soft tissue adoption or changes will happen after 3 months surgery after the surgery. This is the lateral ceph taken preoperatively, and this is the taken this is taken postoperatively, and the ceph tracing was done, and he had ideal markings. And this is a preoperative image, a short upper lip or a small lower jaw, the ceph tracing done. This is a post-op picture. Mandible advancement was done along with lip repositioning. A similar case of lower jaw excess. This is a post-op picture, pre-op and post-op picture. This is a pre-op and post-op picture of the patient. So, by now you all will understand the indications for surgery correction, surgical correction of dentofacial deformities, to know how to diagnose the skeletal problems, being upper jaw problems, lower jaw problems, or a combination of both, or a single tooth problem, or a severe dental, or a severe like a flaring up of upper anteriors. Know various maxillary procedures to correct those problems, to understand the various mandibular procedures, to know the step by step preparation, and by now you must have understood the preparation for surgery. So, you know what are all the complications that might encounter or that might happen, and you know how to manage those complications. So, to summarize, so you know the maxillary osteotomies, mandibular osteotomy procedures, indications for those procedures, and step by step preparations. Okay. Thank you for watching my class.